Good evening, everyone. Welcome to our Henry Ford Allegiance Orthopedics virtual community presentation. My name is Tim Hernandez. I'm from the communications department here at Henry Ford Allegiance Health. I want to thank everyone for attending and taking some time out of your day to do some learning. Before I do introduce our presenter, we have a few housekeeping details I want to review with everyone. Everyone's on mute, so that way it'll help us to limit the background noise. If you do have a question, we encourage that. Or if you want to share a comment, please use the chat option. You can send your questions to all panelists. You can submit those questions anytime during the presentation. If you're on a mobile phone, you may need to tap the screen. There's a little person on the top right corner if you're on your cell phone, or you may need to swipe a little bit and then use that chat feature that's within WebEx. We will do that Q&A at the end of the presentation. We'll try and get to all of your questions. If we do have something we don't have time to get to, we will follow up a little bit later through email as well. If you do have some connection issues, if the video feed keeps dropping, you can call in. There was an email. Your invitation has a phone number on it and a call-in number. As a reminder, this presentation is being recorded. Only myself and our presenter will be filmed, so there will be no attendee information that's being recorded or shared as well. And of course, this is for information. You should see a doctor to help diagnose your particular problems. So right now, it's my privilege to introduce our presenter this evening, Ryan Beekman, MD. Dr. Beekman is a board certified in orthopedic surgery. He specializes in conditions of the hand, wrist, and elbow, including carpal tunnel, nerve disorders, tendinitis, and trigger finger. After earning his medical degree from the University of Michigan, Dr. Beekman completed a residency in orthopedic surgery at Wayne State University and his fellowship at Columbia University. Dr. Beekman leads our Henry Ford Allegiance Orthopedic Hand Services, and he serves as the Executive Medical Director for our surgical subspecialties. So I'd like to welcome Dr. Beekman. Thank you.
We're ready to go. Well, thank you everyone for joining us this evening. Hopefully the information I'm able to present is helpful to you in regards to hand and wrist issues you may have. Certainly it's near and dear to my heart in terms of trying to help people. But we'll go through a few slides, and then please provide us with your questions, and we'll get to as many questions at the end as we can. So tonight we're going to talk about some common hand and wrist issues that honestly most of us have. We're going to talk about carpal tunnel, something that I myself have had and had recently treated. We're going to talk about something called trigger finger as well as thumb arthritis. So we'll get started. Oh, got to grab our pointer. So here we go. I titled it, What's Wrong with My Hands? So I think at some point in life, most of us will have issues with our hands. They may be minor, they may be more significant, but I think a little information is extremely helpful in terms of what do we do when something goes wrong. So carpal tunnel. So carpal tunnel is the most common compressive neuropathy. And so what does that mean? It means basically there's pressure on a nerve, and that causes a problem with your hands. In regards to carpal tunnel, it's numbness and tingling in the fingers. It can be achiness in the forearm and soreness. So it's been basically classified or I shouldn't say classified, but described a long time ago. It was first described in the mid-1800s after somebody broke their wrist. That increases pressure on the nerve at your wrist, and that can cause numbness in the hand. So basically it's numbness, tingling, pain, and it can be weakness as well, because that nerve does go to some muscle within our hand. In regards to anatomy regarding carpal tunnel, so on the left here, which side is left? I guess on the right here you can see a cross section of the wrist. So all the white things, those are the tendons that move our fingers. The yellow thing there is what's called your median nerve. So that is the nerve that goes to the blue shaded area. The blue shaded area is actually where that nerve maps out to. So the sensation in that area goes to that nerve. So when you have carpal tunnel, that's what goes numb. So the thumb, index, middle finger, and half of the ring finger, and pretty much almost everyone who has carpal tunnel has that same distribution of numbness. Although when you wake up in the middle of the night, it often feels like the whole hand may be numb. In regards to why do we get carpal tunnel, I think that's probably the most common question I get. It's interesting. I think human nature says we want to know why. Honestly, as a surgeon, the why doesn't always matter as much as can we fix it. And so, to be perfectly honest, we don't always know. So most carpal tunnel we call idiopathic, which is, we haven't come up with a great explanation. So, but there can be many reasons. So, pregnancy. Women over 40 tend to get it more than men. Being over 40 by itself. We mentioned wrist fractures, so that can cause pressure to increase. So what are the symptoms? Symptoms are basically pressure on that nerve at the wrist, so you can get weakness in the muscle in the thumb right here, and you get numbness in that blue distribution that I showed you. So why does that compression happen? Basically anything that causes swelling within that space is going to put pressure on the nerve. The tendons don't really care so much, but the blood supply to the nerve does. And so when that blood supply goes down, it's just like you slept on your leg. And so that nerve will stop working correctly. So bending the wrist, people often ask, does typing cause carpal tunnel? Typing by itself, probably not as much as people think. Wrists at an extreme in terms of flexion or extension, that can certainly cause carpal tunnel. So if you're doing a plank for too long, then certainly your hands can fall asleep. I try to avoid planks myself. Not all that fun. So what are the symptoms? So symptoms, as we talked about, numbness, tingling. Some people do have pain, not everyone. Some people have more pain than numbness and tingling. Weakness in the thumb muscles. Feeling like your hands fall asleep. Probably the most common period that happens is actually at night, and we really don't know why. Sometimes it's because people sleep on their wrist funny, but sometimes it just happens. So reading the paper for women, doing their hair frequently. I'm not saying anything against men's hair, but as we get older, a lot of us don't have that much hair left. So that is not a huge problem with men. Driving the car, for some reason, just having your wrist in that same position for a long time, the hand tends to fall asleep. A lot of people notice weakness. A lot of people notice they drop things, even though they may not feel weak. And so those little nerve fibers that tell us how hard to pinch can be interrupted, and so that can cause us to drop things even when we think we have a good hold of them. So on occasion it can cause shoulder pain. More commonly it does cause some degree of forearm achiness, usually on kind of the ulnar side or the little finger side of the wrist, just above the hand. In terms of who gets it, so I briefly mentioned this, but basically men tend to get it less than women. In terms of age, usually it's over the age of 40, but certainly people can get it when they're quite young. Pregnancy, very common for women when they're pregnant to get it. Often it does get better when they deliver their baby, but they're certainly at risk for getting it later in life. Other conditions, so certainly diabetes, kidney failure, fluid changes, like problems with the heart can cause issue. Those are actually probably less common than what we call idiopathic, which is we just don't know. People ask repetitive motion, do I type too much? Do I get on my phone too much? Those things are all probably true, but in terms of causing carpal tunnel, we don't know, and they actually don't cause it as much as we might think. Heavy grip activities definitely aggravate it. I noticed that myself. In regards to diagnosis, just talking to patients, that's actually probably the easiest way to diagnose carpal tunnel. Do your hands fall asleep at night? Do your hands fall asleep when you're driving, doing your hair? And that's super common. And I probably get a better idea in terms of just talking to people about whether they have carpal tunnel than I do by any studies or other intervention. A physical exam, we tap on the nerve, and if it's really irritable and makes your fingers tingle a lot, that's a good idea that you may have carpal tunnel. We do sometimes get what's called an EMG or nerve studies. We don't always get it, but that sometimes helps confirm the diagnosis. But as I said, just talking to patients is probably the best way to diagnose it. So exam, signs of nerve irritation. If you bend your wrist for too long, does it fall asleep? If I tap on the nerve at your wrist, does it make it tingle? So that's very common. Later findings, so if people have had it for a while, then you can get weakness in the thumb muscle right at the base of the thumb, and sometimes you'll actually notice that there's a void of muscle there. And then do people have numbness in their fingers? Usually that's later on. People have had it for some time when they have numbness all the time. In terms of treatment options, in terms of data of things that really prove effective long-term, there are not a lot of treatment options. So night splints, what do? Basically keep your wrist straight. Pressure is lowest when the wrist is straight, and those can be very helpful for a lot of people. In terms of steroid injection, that's a common one. Some people always do it. Some surgeons always do it. Some people don't. I tend to not do it very often. It can be effective, but it's usually not very effective, or I should say it's not effective for very long. On average, only about 20% of people at a year have improvement after an injection. And in my experience, injections usually last about a month. So it can be a good test if you're not sure if somebody has carpal tunnel in terms of the injection. Other treatments, people ask about anti-inflammatories, changing their position. Certainly you always want to make sure when you're typing your wrist isn't in an extreme of position. That can help some people. Anti-inflammatories, there's not a lot of data that they're particularly effective. Surgery, when we do talk about surgery, surgery can be extremely effective. I have had patients say, you know, I've been told carpal tunnel surgery didn't help. And usually that's because people didn't necessarily have carpal tunnel. So usually surgery is extremely effective, and I'd say most patients are very satisfied. In fact, carpal tunnel surgery patients are probably my most satisfied patients that I have. So in terms of surgical treatment, you can see here, this is a standard incision in the palm. That's actually probably a little bigger than most people do now. Mine's probably, on average, about 3/4 of an inch. But basically, we numb up the area just right there at the wrist. There are a couple different ways to do that. We open up that main incision, which is right off the palm. And if you can see right here, I actually had mine done 6 weeks ago. And so incision is right about there. And basically that small incision, we cut the tight band that goes across the nerve and the tendons there. We do not mess with the nerve. We don't mess with the tendons. You just cut the band. It pops that open and just gives it more space. Once you've done that, the pressure relief is immediate. And I have people in recovery that say, wow, my hand feels a lot better already. So in terms of aftercare, people think that they'll be off work for a long period of time. Basically, it's a fairly quick recovery. Depends on what you do for a living. For me, I went back to work about 3 days later. In terms of aftercare, we do a big Band-Aid. So a lot of people are worried about their hand being in a brace or a big dressing, but really you don't have much. You can get your fingers moving right away. That prevents us from having to send people to therapy. You can do most things immediately. I noticed that I couldn't pick up a case of pop for a couple weeks, but the rest of the stuff in terms of life I could do right away. In terms of return to work, it depends on what your job is. In heavy industry, people returning to full duty is usually around 4 to 6 weeks. If you do what I do, like I said, I returned within a couple days. But my wife made me put in a dishwasher for her mom 2 days after surgery, and I was able to get through it. So next topic. So trigger finger. And so often people come in and say, hey, my finger gets stuck in the morning, and this is exactly what people show me when they come in. So this is something called trigger finger. Trigger finger, what is it? Basically, the tendon in your finger gets stuck. So a tendon, we have 2 tendons to each finger, one to the thumb, and those tendons go under a very tight band in the palm. So often when people get carpal tunnel, they can also get trigger finger, and that's basically related to tendon swelling. And so the tendons swell a little bit. They then start to go under that band. They get a little more thick and swollen, and then they start to get caught and trigger. Now, sometimes people can have pain without triggering, but often they do trigger. Often it's in the morning. By the time they come to the office to see us at 10, 11 o'clock, sometimes it's already gone. Many people feel like the finger is dislocating because that tendon works out at the joint, and so they'll feel like that joint is popping in and out. Thankfully, most often it is not. Here's a good picture of the tendon pulleys. So the red structures here are the pulleys themselves. The one farthest to the left is what's called the A1 pulley. That's kind of most critical with tendon triggering. And you can see a demonstration here in the other picture of the finger being straight and then the nodule on the tendon kind of getting stuck as it goes into that pulley. In terms of cause, much like carpal tunnel, over 40, women more than men. Diabetes does play a role. Up to 10% of diabetics can get trigger fingers. I've seen people who can get a trigger finger in every single finger. Some people with diabetes, some people not. In terms of phones, video games, all those things, once again, it really hasn't changed all that much. Heavy grip, a lot of heavy pressure does tend to make trigger fingers worse, but often we're not sure of the exact cause. In terms of diagnosis, really, once again, history. So Hey, I wake up in the morning, my finger gets stuck, and then it gets better over the next couple hours. When it gets worse, sometimes people come in and their finger will be completely locked down, just like this. So people typically are very tender. They're tender right over the palm where it's catching. The knuckle can get sore. I found, I actually had a trigger finger as well, and I found that my whole finger just kind of ached and was sore. You can actually feel in the palm right here where the bands are that it's tender, and that you can actually feel kind of a crunch underneath the tendon in regards to the trigger finger. So physical exam, tenderness over the tendon, you can almost feel like a little crunch there. Pain, as I mentioned, pain can be out over the knuckle, the first knuckle, or what we call the PIP joint. The tendon's thick, and actually you can feel it catches, it moves under. And I usually describe it as kind of the shoelace. So you're trying to get the shoelaces back in your kid's shoe because they took them out for, whatever reason. And you can't get it in because the end of that shoelace has been dragged through the mud and is nice and thick. And so as you put it through, it just kind of gets caught and stuck, and that's exactly what the tendon is doing. So in terms of non-operative treatment, anti-inflammatories, once again, not particularly effective in most situations for some reason. We do often do what's called a steroid injection for this. This can be very effective. I'd say about 50% of the time, although the literature varies, it can be quite effective. In terms of how many times will you do that? Often we'll do it once, maybe twice, depending on the situation, but if the first one hasn't worked, often the second one doesn't cure it. If the injection doesn't work, then surgery is quite effective, and sometimes that's what we do depending on how long the tendon has been catching. So this is an example of an injection, really a fairly short, small needle, and we basically inject right into the sheath, which is a kind of covering around that tendon. That pulley is part of that sheath, and so we inject into that sheath that shrinks that tendon down, and that can make the catching stop. In terms of surgical treatment, we make about a 1/2-inch incision right in the palm, right where the blue area is outlined there, and right over that band. And we basically just clip that band or cut that band, much like carpal tunnel, but in this case to prevent the tendon from getting stuck. We really only need to numb up the finger right where that incision is, and then after we've done that or release the band, we will actually have people make a fist to make sure it doesn't catch. In terms of after, very similar to carpal tunnel, we can move it right away. So I do have people keep it clean and dry because water kind of makes it junky, so we don't like that. But a big Band-Aid, move it right away. Most people don't need therapy, and it can be sore for a couple months after surgery. We have a question.
We have a question. It's about trigger finger. Is Dupuytren's the same as trigger finger? I think I'm saying that right.
Fantastic question. So Dupuytren's disease is actually not the same as a trigger finger. A trigger finger is where the tendon gets stuck. So you bend down, it gets stuck, you pop it open. Dupuytren's disease is actually a thickening of the skin or thickening of the fibers under your skin. So I don't know, can we zoom on my hand? Is that possible? So I actually have, now Dupuytren's disease can make people prone to developing a trigger finger, but they're really two things. So if we zoom on my hand, gotta make sure I get on camera here. So I don't know if you can see it, but I basically developed, or my Dupuytren's, which is right here. So this is the thickness here. Okay, so that is Dupuytren's disease. I did have a trigger finger, but I had that fixed last year by Dr. Aubin, my partner. And so the Dupuytren's is essentially completely different than the trigger, but it does make you prone to developing triggers. So hopefully that answers the question. And Dupuytren's is very genetic. It's mom and dad's fault. I blame Dr. Aubin, but it's actually not her fault. So, in terms of trigger finger, we mentioned the soreness. Mine was really sore for 3 or 4 months, probably because the Dupuytren's was getting a little worse at that time. But in general, it's not too bad. So our final topic of the day. So my thumb hurts. Incredibly common. I joke, not joke, but I say that if you live long enough, you're going to get thumb arthritis. And so we're going to talk a little bit about thumb arthritis. So what is it? Who gets it? Like I said, if you live long enough, you're probably going to get it. The reason is that the thumb joint is very loose, and so it tends to move around quite a bit. And cartilage does not like a lot of motion or a lot of different loading. And so over time, that does tend to wear out. Now, we're all a little bit different genetically, and so some people's thumbs wear out sooner than others. So it's the most common arthritic joint in the hand. It's more common in women. They tend to get it earlier. So about a third of women at age 40 already have X-ray changes, which is just a massive number. The good thing is that a lot of those people don't have any symptoms. In terms of reasons, as I said, genetics is huge. Sometimes people have had an injury that can kind of accelerate the process. But clearly genetics, or our genes that our mom and dad give us, plays a huge role. In terms of diagnosis, I can often look at somebody's hand and kind of tell. People come in and they point right to the base of their thumb and they're like, it's really sore, I pinch, I can't open jars, I can't get those plastic water bottles open. And so that's often a fairly easy diagnosis. So on the left, I have to get my bearings here, yep, so left. So you can see right here that this is basically a very arthritic joint. If we look here on the right, you have a good joint space. You can see the difference between the two bones. You have a nice 2 millimeters or 1/8 of an inch there. And so that's a normal looking thumb. And then when we look at the arthritic thumb, you can see there's no real space. The bone is really hard and white. When the cartilage goes away, the bone gets more dense. The bump, which people feel over here, gets bigger in part because of swelling, but also because the thumb tends to slide out a little bit. So you can see that in position, this one's centered here, right on the bone, and this one has slid out, a good 1/4 inch. And so often that bump gets bigger. So physical exam is huge. X-rays do help confirm the diagnosis. So in terms of treatment, so thumb arthritis is super common. Like I said, a lot of people have no symptoms of it. Often we just try a simple splint. It's soft, it keeps the thumb from, it keeps it warm, slows it down just enough that often it can get better. X-rays don't tell us how much pain people have in regards to their thumb arthritis. In terms of medications, once again, anti-inflammatories help some, but not all that much. Injections. So injections can be very helpful. The problem with injections, you don't know if they're going to last a month or they're going to last for years. They really can do both. And then we do have effective surgeries for thumb arthritis. They are not, as I tell people, get quick, easy procedures. They do take time to mature after and for people to be very happy with them, but they can be very effective in somebody you've tried everything else and they just don't get better. In terms of surgical treatment, there are multiple surgical options. Really all of them revolve around the same main surgery, which is actually removal of this bone here. So this bone, now removed, is called the trapezium. And so it goes between the base of the thumb, the metacarpal here, and the wrist bones. And so we actually take out that bone, and that gets rid of the arthritis. You would say that, well, my thumb's going to fall apart. Thankfully, it does not. So we actually replace that bone in most situations with a tendon. This is actually the tendon that we use right here. It's called the flexor carpi radialis. And so we use that to fill that space. They do make joint replacements for thumbs, but actually they're no more effective than using your own body materials, and so most of us like to keep it simple and do that. In terms of results, people are very happy with surgeries most of the time. So 90% of people are happy or very happy. That doesn't mean they have zero pain, but most people do very well. To give you an example, with total knee arthroplasty or knee replacements, about 82% of people on average are happy or very happy. So overall, it's a good procedure that works well long term. The biggest issue, as I mentioned, is it can take up to 6 to 12 months for people to be very happy. And the reason is their grip strength is not great, it's still sore, and it just takes time to really mature. And that's very similar to knee replacements in regards to the recovery after. So that is the end of the formal presentation today, and hopefully we have some questions, and we'll get on to questions.
Yep, and again, a reminder to everyone that's attending, if you could just submit your questions in the chat section, just send it to all panelists, and then we'll try and get to those as we get them. I had one from an individual. They had radial head repair. Mm-hmm. They said they don't have symptoms for carpal tunnel, but could it happen? And they also, two-part question, I do have trigger finger on the hand of the arm that had the radial head repair. Mm-hmm.
So what is the radial head? The radial head is actually part of the radius. So the radius is one of the two bones in the forearm. The radial head is up near the elbow on the outside. When you twist, your radial head moves. And so radial head repair is you can fall and break that, and you can either fix it with screws and a plate, or you can actually replace it. I I will comment that often after people have been injured in an arm, they can develop carpal tunnel, probably related to a little swelling. I think the trigger finger could potentially as well, although it's hard to tell. So could just be coincidence that the trigger finger developed on that side, but certainly could happen. And then, as I mentioned, carpal tunnel and trigger finger often go hand in hand. If it's more pain in that finger specifically, it's going to be more related to the trigger finger. If it's numbness and tingling in the thumb, index, and middle finger, then that's where you'd be worried about carpal tunnel. Does it wake you up at night? Things like that. So they can definitely be related together.
Okay. The next one is about carpal tunnel. Is it hereditary? I think you kind of talked a little bit. And then induced by repetitive motion, or both?
So many people get it. I think it would be difficult to say if it's hereditary. I don't think we have good data on that. Repetitive motion, like I said, the good thing is it doesn't necessarily matter the cause. We can fix it. Heavy repetitive grip, at least when they've studied it, does tend to make people prone to carpal tunnel. So if you ask a lot of carpenters, they're using a hammer all day or a pneumatic nail gun. They call it carpenter's cramp. And so a lot of younger people who do that can get it. But that heavy grip is probably more important than purely repetitive motion. Repetitive motion, typing is certainly very repetitive. A lot of people with that actually get more kind of overused tendinitis than they do carpal tunnel necessarily. But like I said, we always have a fix if that's what it is.
Okay. And you did mention tendinitis. We have a question about that. Their doctor said they have tendinitis. They've had it for about 6 years. They're a guitarist, so obviously their hands are important. They went to therapy and strengthened it, but then they couldn't keep going to therapy, and it still hurts. So they're kind of wondering if they should get a reassessment.
I'd say 6 years. I'm not very patient. 6 years, I don't think I'd be able to wait that long. So interestingly, guitar playing, a lot of guitar players, depends on which hand, can get something called FCR tendinitis. So I mentioned that tendon we use for thumb arthritis procedures, that's called the FCR. And guitarists tend to really bend their wrist. And so I've seen people develop tendinitis of that. If it's still causing you pain after that long, I definitely think it bears looking into, especially if it's affecting your ability to play, your quality of life. If something's minor, most of us give it time, but I think 6 years is a long time. And so that's certainly a possibility, that kind of position in that tendon. So what do you do in that situation? Sometimes a splint for short times can be very helpful. Sometimes we will do an injection. And I've actually, in a couple situations, two guitarists actually release the tight band over that tendon, which will give it space and stop that irritation of the tendon.
Okay. I don't think we covered this. What treatment is there for osteoarthritis in the wrist?
So osteoarthritis in the wrist. So we talked about osteoarthritis in the thumb. Osteoarthritis in the wrist is very similar in the thumb in that a lot of people can have it as they get older, but they may not necessarily have pain. So if you have pain, we basically go through the same algorithm. My job is pretty easy. We splint. We talk about anti-inflammatories. We consider injection. With osteoarthritis of the wrist, it depends on where it is. There are a couple different spots. Let me go back. And I'll use this picture here. So wrist arthritis. So this is a picture of the wrist. This is the thumb arthritis. The wrist, this is called the radius right here. And these are 8 wrist bones. So if people develop arthritis here, and they failed their other options, splinting, injections, things like that, we actually often remove this bone. And that may seem extreme, but basically it gets rid of the arthritis. We then have to do something with the other bones to give the wrist stability. And so you can actually lock these 4 bones together, or you can actually take out these 3 bones. What you do with that is you create a new joint. So this joint moves down to here, and so that is a very effective treatment. It does limit motion a little bit, but people would rather trade motion for pain. And so if it does hurt, both of those can be very effective options.
We have another question. Is it possible to get trigger thumb? They said their thumb sometimes has a click to it and then a sharp pain shooting into the thumb.
Absolutely. Thumbs may be the most common trigger finger. Actually, kids can get trigger thumbs. We often have small kid hits his thumb, parents notice, they're like, my thumb's stuck, or my son's thumb is stuck. And And so basically same concept, the tendon over the thumb, which is right here, will get thick and get stuck. And so absolutely the same treatment basically applies to the thumb as it does to the other digits.
Okay. Kind of going back to the arthritis question, this individual has rheumatoid arthritis. I'm assuming that's what RA stands for. Mm-hmm. Do you do joint replacement in fingers besides the thumb?
We do. So generally let me see if I can find a picture of a finger. I don't know if I have one. So in general, maybe I can point to my own fingers. So with the small joints at the tip of our hand, we'll try to zoom in here. So right here at there we go. Sorry, I smashed my finger there. So at this small joint here, generally we will fuse that. That means get rid of the joint. That's the easiest way to deal with that. Small joint replacements there just aren't strong enough. At this knuckle, which is called the proximal interphalangeal joint, we do have joint replacements, and those can be quite effective, especially in rheumatoid arthritis. We actually do have joint replacements at these knuckles as well, and those actually you can see in both rheumatoid arthritis as well as just wear and tear arthritis, or osteoarthritis as we would call it. So yes, depends on the person, depends on the finger, but we have a whole number of treatment options if the simple things don't work.
Okay. We have another question. How do you treat chronic, if I'm going to say this right, de Quervain syndrome?
Mm-hmm. So de Quervain's is a form of tendonitis. It's actually at the wrist. So it's actually very much like a trigger finger. It's just a bigger tendon. So de Quervain's is right here on the thumb side of the wrist. It will hurt right at the bump. That feels like bone, but actually that's tendon. So thumb arthritis would be here. De Quervain's is here. So de Quervain's, we treat it identical to a trigger finger, except splinting is usually more effective, because if we put that in a splint, say it's been going on a short time, we put it in a splint, we really stop the motion there. That can help the tendon calm down. Splinting a finger for a trigger finger just isn't feasible from a life standpoint. So de Quervain's, we generally treat it with a splint. Now you mentioned chronic. So if it's been going on a long time, the splints are not particularly effective. Usually then we'll start with an injection. If that doesn't quickly work, we'll do surgery. So surgery for that involves a little incision about a ½ inch across, right there, hard to see. And basically we then release the band over those nerves. So the band actually goes across, so we release the band here. The reason we release it farther towards the back is that when you move your wrist, those tendons want to go towards the palm. And so we release it and back to prevent those tendons after release from going towards the palm. We do splint it for most of us splint it for a couple weeks after, but that's very effective. And for some reason, the last 2 years, I've done more releases for that than I have in the last 10. It just seems to be super common right now.
Okay. And kind of a two-part question back to carpal tunnel. What can help treat it? Is it heat or ice? I guess what's more effective? And then can carpal tunnel come back after having surgery to repair?
Very good question. Heat or ice, I don't know. I usually say whatever feels better. If you're starting to go in the morning, probably heating things up in a nice warm shower works better than anything. Ice, at the end of the day, I always say ice in the hand is tough, because a lot of women, their hands will actually turn blue if they get too cold. So really, if it helps, I think either one is effective, and it's kind of a trial and error process. In terms of can you get it after? That's an excellent question. So the literature would say about 10 to 15% of people can get it again. I think people are most at risk. So what happens? So we release that tight band when we fix carpal tunnel. So that band pops open and heals. If you get new swelling in that space, you can get pressure on the nerve and essentially get carpal tunnel again. Some people will get carpal tunnel very early in life, 20s, 30s. I tell most of those people, when you hit 40 to 50 like the rest of us, you certainly could get it again. If you've had your carpal tunnel fixed when you're in your 40s and 50s, I think the odds of having it again are much lower. So yes, you certainly can get it. Or say you broke your wrist after you had carpal tunnel fixed. New swelling, you can get carpal tunnel again. What do you do to fix it? You do the same thing you did before, which is basically release that tight band, make sure there's no pressure on that nerve, and then usually it does get better.
Okay. And I think this one's kind of related to the gel pads designed for like when people are typing and using the keyboards and mouse. Are those a good idea to use proactively?
I think they are if you're an awkward typer. So, depending on where your wrist position is, wrist straight has the least pressure on the nerve. So if you're an awkward typer and you need that little support to put your hands in the right position, perfect. I think often people either have their keyboard too high, too low, so you really want it where your arms can be kind of at rest. Also, I think it's very important just to take breaks. You know, get up, stretch, go have a couple Oreos in the middle of the day like I do. Movement is critical, and staying in one position for too long is problematic. But all those little aids can be helpful, and just kind of trial and error in terms of what works.
Okay, kind of going with that movement part, and going back to osteoarthritis. Somebody had a physical therapist tell them that motion is lotion in regards to treating their osteoarthritis in the wrist. And I think you mentioned saying to splint. So I guess what would work, immobilizing or exercising the joint, I guess?
So I think, now as I've gotten older, keeping moving is critical in terms of keeping your body active and from aching. I notice that if I'm not doing something physically active for a few days, I definitely have more aches and pains. In terms of that question, so if somebody comes in and say they had a fall, they didn't break anything, but their wrist arthritis really was aggravated. In that case, you're like, okay, it's really flared up. Moving in that situation probably isn't going to help. So we'll use a splint to slow it down for a short time. In general, though, if you're otherwise doing okay, maybe you have occasional aches and pains, maybe you have a little wrist arthritis, maybe you don't, I think it is critical to keep moving in that situation. Now, should you overdo it or try to strengthen a joint with arthritis in it, I generally avoid that. You want to live your life, do the things you like to do, and I think strengthening when there's a little arthritis probably is not the best idea.
Okay, so some movement, but...
In general, keep moving. If you have an injury or a really aggravated joint, slowing it down for a time can help it get better.
Perfect, okay. And then one last question. A person saying their thumbs have retracted into their palms. Can that be fixed?
So that's also a good question. So I don't have a picture of it here. There's something called a Z deformity. So often I mentioned in the thumb, it tends to slide out, and I'll get to the picture here. So as the bone slides out at the base of the thumb, what often happens is the thumb does fall into the palm. So kind of like that. And then the rest of the thumb will kind of start to go back, and that actually helps to compensate. So if that didn't happen, you wouldn't be able to grab anything. People who have that problem do find that it's hard to grab around a glass or around a container or around a pop can. If it doesn't hurt, most surgeons would leave it alone, assuming people are reasonably functional. You can get into trouble if you're trying to treat just the position of the thumb. If it does hurt, then it's absolutely reasonable to treat it. So it can be fixed, but the question is, should you always? And the answer is sometimes yes, sometimes no.
Okay. I think that's going to wrap it up for questions tonight. So thank you, Dr. Beekman, for taking the time to answer. We had quite a few great questions.
All right.
If you do have any further questions for attendees, you can always contact the Henry Ford Allegiance Orthopedic Office.
Absolutely.
I'm going to add a link right now and the phone number for that in the chat window, so if you want to grab that. I do want to thank you again, Dr. Beekman, for taking time this evening to be here with us and to discuss all this information. Thank all the attendees as well for your questions and getting hopefully some good information to kind of help you get some relief. And again, as always, you should always see a doctor to help diagnose your particular problems. So I'd like to thank everyone for attending. Thank you, Dr. Beekman, and everybody have a good evening.
Thank you for having me.